Thank you, Prof. Mervet, for the invitation. Good afternoon, dear colleagues and professors. I'm going to present a case of supraventricular tachycardia that was ablated by the team of Prof. Mervet in her private center. The history of the patient: that she was a female, her age was 42 years old, she was hypothyroid on Eltroxin. She presented with recurrent episodes of supraventricular tachycardia terminated by IV verapamil, and 2 episodes needed DC shock, and she was on amiodarone and metoprolol, so she was referred for EP study and ablation after stoppage of her drugs, especially stopping amiodarone for 1 month. Her 12-lead ECG in the clinic was a normal sinus rhythm and didn't show any signs of pre-excitation, but surprisingly, when she was taken to the EP lab and the 12-lead was connected to the patient, there was manifest pre-excitation, and it was noticed that it has a left pathway versing a left posterior accessory pathway. And actually, when we did the femoral vein puncture, there was an abnormal course of the wires of the femoral sheaths, the short ones. So we took a 0.032 wire to see the course, which was hemiazygous to azygous, and then to the superior vena cava, and then to the right atrium. So we performed venography using a long cheese, and there was no communication between the femoral vein to the IVC and the right atrium, and actually the deflectable catheter failed to cross the heart with limited motion, so we thought that there was an abnormal venous system. So actually we took 2 left subclavian vein punctures, and we inserted a 5 French quadripolar catheter inside the CS, and then exchanged this with a 7 French decapolar catheter, as the later was not inserted directly to the CS. So we had like this roadmap with the 5 French quadripolar, and then we inserted the 7 French decapolar. With catheter manipulation, the tachycardia was induced, and we noted the eccentric pattern with the shortest VA time at CS 3 and 4. So we bracketed the shortest VA time between CS 1 and 2 and CS 5 and 6. And left bundle aberrancy caused deceleration of the tachycardia, so we were sure that it was a left-sided accessory pathway. A 7 French ablation catheter was inserted via the right femoral artery, and this was carried out by the more than 30 years of experience person, Prof. Mervet Abul Maati. And actually, because we are used to do the transeptal puncture, so this case was a little bit difficult for my generation. So Prof. Mervet did the aorta mitral thing via the right femoral artery using a catheter. It was an irrigated tip catheter, and the best signal was achieved from the left posterior segment. And ablation at the left posterior segment on the mitral annulus immediately terminated the tachycardia and results in termination of the pre-excitation. And we can see the VA dissociation noted from the RV and LV pacing, and atrial pacing showed no pre-excitation. And we waited for 40 minutes with no recurrence of pre-excitation or even the VA connection. And this is ECG post-ablation. The take-home messages: knowing different anatomical variants will help you as an electrophysiologist to change the strategy rapidly during the procedure. And this is a very important point, that you do not struggle on the same method. You have to change your mind, and you have to have the team. So working as a team with the expertise of seniors will allow the achievement of success in complicated cases, and this also done in a very rapid way. This case didn't take like 30 minutes inside the cath lab. I know it's quite easy, but the challenging thing that it was like very easy for us to see that it was an hemiazygous to azygous system, and then we took the catheter retrograde through the femoral artery, and when Prof. Mervet sees that, it was like the everyday practice for her, so the case didn't take too much. So working as a team and rapid change of the strategy will allow the operator to achieve success without complications. Thank you very much.
Thank you very much, Mohamed. We can open for discussion. Anyone has a question?
دكتور ألفي
إبراهيم يوسف.
تسلم الإيادي طبعا في الأول، وحاجة طبعا مش غريبة عن التيم بتاع حضراتكم برئاسة الدكتورة ميرفت. regarding الأكسس other than arterial access، لو احتاجنا نعمل سيبتوستومي available والسيبتوستومي subclavian أو jugular access or not؟
Yeah, of course, we could do the septostomy via the left subclavian with bending the broken brow needle to take the shape of the sheath, and do this using transesophageal echo or with help also of a catheter in the non-coronary cusp to show this. But the easiest thing, because the rapid changing of the method during the procedure and being safe, because this was a child actually, so we don't need to do any risk for this. But we were lucky enough that the accessory pathway was at an easy area to be reached via retrograde. But the point you said, Prof. Ibrahim, is very intelligent, and if the accessory pathway was unreachable with the retrograde femoral artery, we could do the subclavian.
But not subclavian, right? Internal jugular.
Internal jugular, yes.
When I was in the meeting with HRS, I met Zabine Ernst because she did this a lot. And she said that in these cases, she uses the axillary vein puncture. We all use for pacemaker. The right axillary vein, she can do this transeptal. Of course, intracardiac echo or transesophageal echo guided, because we met a case with AFib, and we have to cancel the case because he had interrupted inferior vena cava, and we could not do the transeptal, and actually we weighed the risk benefit ratio, so we decided to cancel the case and to postpone until we get some expert with the internal jugular transeptal, because even when I asked Javier Moreno, he said, yes, we can do this, but how about movement of the catheter in the left atrium, especially for AFib case? For this case, yes, we can go through right internal jugular to do the transeptal. I think Rania and me, we did similar case, but dextrocardia from the femoral vein. You just imagine what you are doing and use the intracardiac echo, transesophageal echo to help you to minimize the risk for the patient.
And our friends in United States, we met last meeting in San Diego. They use a lot of intracardiac echo.
Of course, it's
easy to do the via the jugular approach. And we have a colleague also who was trained in Russia, which did the AFib ablation using stereotaxis, and actually they did the transeptal also from the jugular approaches. This is a very important point to be knowing while having a procedure of this abnormal venous system.
Okay, thank you, Mohamed.
Thank you very much.